Hello, everybody. This is Dr. Andrew Gums from, yeah, not ready, but I'm working on it. Editor-in-Chief of Artificial Intelligence Surgery. Vincent, I'm going to let you chime in. Is this episode 48 of Artificial
Yeah, it's
Intelligence
episode.
Surgery, our podcast?
Yeah,
Fantastic. I'm going to let you go ahead and introduce our next guest.
yeah. Thanks. Super. Yeah. We're episode 48. We're approaching 50. We're very happy to have Alex Joseph on today, on our podcast. I think you're in England right now, Alex. Right? You're broadcasting from there. Alex is a mechanical engineer, true, and he's got a lot of deep expertise in medical devices and health tech innovation. He's at Cambridge Consulting. And Alex, what we usually do is allow our guests to introduce themselves and give our audience a little background about what they've been doing, and then we jump into and just freewheel back and forth. So welcome to episode 48.
Sounds great.
Yeah,
Thanks for having me.
Quickly, and just remind everybody that we're part of Artificial Intelligence Surgery, the first journal dedicated exclusively to artificial intelligence and surgery. So, Alex, please introduce yourself so our viewers and Vincent can get to know you.
Sure, absolutely. So thanks for having me. It's really exciting to be here and to catch up with you both. Had a listen to some of the podcasts earlier today, so it's really exciting to join such esteemed guests on your podcast. So yes, Alex Joseph. I work at Cambridge Consultants, and we are an innovation and sort of deep tech consultancy, as we like to call it. So we help people design products that are going to transform markets. And as a business, we cover industrial, consumer, energy, sustainability, medical devices, life sciences, surgical systems, really broad range. My focus is on medical devices, more specifically these days, mostly surgical systems. That could be anything from an end effector that goes inside a body. It could be a surgeon console. It could be some modeling of maybe a surgical procedure, looking at workflows, or it could be the modeling of the kinematics of a robot. It could be doing due diligence for an acquisition, which I did a few of last year, and they're quite fun. I've been at CC it's coming up to 8 years. Before that, I was at the University of Bath. My background is in electromechanical engineering, so really the interface between mechanical and electrical, and you end up doing a little bit of prototype software in there normally as well when you want to move things around. I'm very lucky that I have worked across a really broad range of projects, and Cambridge Consultants has 500 projects a year. So there's always something really exciting to get to dive into, and I've worked across drug delivery, some consumer stuff, some industrial stuff, diagnostics machines, really, really wide range of things.
So Alex, I majored in archaeological studies. So I'd like to go a little bit further back. Where are you originally from, if I may ask? And where did you grow up? And let us know.
For sure. So I grew up in Northwest London. My dad is an engineer turned banker.
Which soccer team? You're gonna have to. I think you have 7 in London or something insane like that, right?
Sorry, which
football team? So
well, I'm a rugby boy, unfortunately. So as unpopular as that'll make it, it's probably Saracens is my local team. They're about 10 miles away.
Is Saracens they're a rugby team? No.
Yeah, they're a rugby team. Yeah. They're,
So I understand if what football team is closest to you. What part?
So Watford is the closest team.
Wow.
That you may have heard of.
I wasn't even sure about that. But I actually I prefer rugby myself for I'm sure all of the same reasons. I've been following the French national team for a while. I remember the 5 Nations Cup, now the 6 Nations Cup, and I was very pleased with Italy's progress this year in the 6 Nations. I couldn't believe it. They almost beat France this year.
For sure. And you spend a lot of time in Georgia, right? And that team is absolutely flying right now. They're doing so well. The sport's growing enormously.
Yeah, no, absolutely. There are some big guys out here, so I think they have a bright future indeed. But I digress now. But okay, now I know where you are in London. And when did you switch, or not switch, but when did you decide to, you're a mechanical engineer, and when did you go into the kind of the business side of things, or are you in the development side of things? Are you in the, what part of this process are
What a
intimately
great
involved?
question. What a great question. So as a consultancy, it's really important that the people who are out in the world selling our work have a really technical background, because ultimately we're solving business problems, but we're also solving technical problems. And the companies that try and solve the commercial problem without understanding the technology ultimately don't do very well. But vice versa, people who try and push technology to the market without understanding why people are going to use it or what their reimbursement route is, also really struggle. So for us to be able to best serve our clients, finding people who sit at that intersection between the two and can translate the commercial need to the technologists and vice versa is quite an important role. And it's also really fun because you get to context switch between those two skill sets really continuously and translate backwards and forwards. So I've been doing that for about formally in my role since the beginning of the year, but really growing into that role over the last 4 or 5 years.
Okay. So, one thing do you work exclusively in Europe, or do you also work with companies in America?
We work with companies anywhere in the world, with a few exceptions, which maybe we won't dive into.
Yeah.
But I was in Japan 2 weeks ago talking at Japan Biodesign, which is connected with Stanford Biodesign, which is a design philosophy. It's a process of how you go through and do sustainable design, sustainable medical device design. But last year I spent quite a lot of time in the States. We have an office in Boston as well. So really we work all over the place. Most of our market is the US. The US has a really booming medical device and surgical system market at the moment. It's also one connected health economy. So it's, if you design a device that's going to go into the US and it passes its FDA, whether that's 510K or PMA or de novo, once you're on the market there, you've got access to, 350 million population. And actually you can then translate that device to the rest of the world. So we see a lot of people going US first rather than Europe first or otherwise.
So, I have a question for you. Since, I grew up in the United States, but I currently live in Europe. One thing I've noticed about, I don't even know how to phrase it without ruffling too many feathers, but I've noticed that in America, people, potential investors, potential collaborators are very interested in a product that has a very short distance before it can start generating money. So I see that the vision is very limited. The projects are in a way much less grandiose. On the contrary, in Europe, they have money for much larger projects, much more, which is beautiful on one hand, but on the other hand, I've seen a lot of companies that have even managed to get a lot of money, but they have never really created a product that goes to market and actually makes a return on investment. So I was very, I was surprised by this vast difference. Do you know at all? Have you noticed a similar thing? How is Japan different? If what I'm saying you've noticed, or
Japan? Well, I'll talk about Japan quickly first. Japan is a completely different kettle of fish. In Japan, a lot of the culture of how you work is very different. So it's kind of frowned upon still to change job more than once or twice in your career. And people will go work for these large corporates like Hitachi or Fujifilm or Sony or Sysmex, and they'll stay there for 30 to 40 years. And they really go and become deep technical experts in their field, probably more expertise, like deep technical expertise in Japan than almost anywhere else, because it's almost like an academic research institution, and then they push technology out. So a really good example that you'll have seen recently is Sony recently showed a new demo of their microsurgical system at ICRA, which was in Yokohama 2 weeks ago. And that system is really, really cool. The manipulators are super tiny. It's got force feedback built into it. It's a really transformational system. But that's clearly been developed from a technology push and not with user insight. And actually, when you go and talk to the team about that, in depth, and you say, well, how are you going to manage sterility in the OR? How are you going to manage draping? How are you going to keep what if the surgeon needs to go interact with the person? How do they then re-interact with the console? Have you thought about the surgical workflow of how you set this up and how you move it around the OR? And that stuff's really lacking. Whereas if you look at some other equivalent systems in Europe, so if you look at Simani by MMI, which just got its FDA approval a few weeks ago, maybe it was a month or two ago, they've really thought about their user workflows when you go and talk to them. So there's a real interesting difference there. The other thing I think we see in the US is, especially over the last 15, 20 years, there's been this tech development fail fast mindset coming out of Silicon Valley. And a lot of the investment groups want that from their investments. And medtech is not a 3 to 5 year return on investment. It's 8, 10, 12, 15, depending what you're doing. You know, if you're developing a de novo class 3 device and there's no insurance code for it, you could be another 5 years post approval before you're even getting paid for it. And I think that really pushes people who want to seek investment outside of the typical medtech VCs to generate revenue faster. Whereas in Europe, we don't have that so much.
And so how do you think that's going to translate into future development? Like who's right? You know, what is, you know, obviously you don't have a crystal ball, but I guess I don't know the answer, obviously. I mean, I think there's, you know, the Americans, obviously, there's a reason you put an emphasis on a return on your investment. I mean, you know, it's hard to criticize the American economy in the sense that they know how to make money, if you will. But as far as society is concerned, you know, I'm very pleased in Europe that they have bigger, you know, a bigger view of healthcare and of how to take care of its citizens. And I find it's, you know, am I being overly optimistic? You know, like, you know, which do you think is, you know, obviously it's easy. You could of course say a little bit of both, but kind of what is you've obviously seen a lot of new developments, a lot of med tech. Where are the success stories that you're seeing coming out of? Are they all coming out of America? Do you think Europe you think it's Europe? You think Japan, China, or what have you?
I think the most important thing, and the thing we should all stay focused on, is getting the technology and the highest standard of care to the patients. That's our number one focus. And then you can think about what's the right way to do that. So you're right, there's two options. It's let's get a minimum viable system to the market, start generating revenue, start learning what works well, what doesn't work, see what the market adoption's like, take all those learnings. We've now got some revenue. We need a bit less investment. Let's get a Gen 2 to market, and so on. The risk with that is if you put the wrong MVP onto the market, that's it. No one's going to trust your brand, and you don't have any market traction. The flip side is you spend a lot of time developing a larger, more transformative product, and then you take that to market. But what if you're not right, or it takes you too long to get there, and someone else has already built brand rapport and stickiness to their brand, and you're too late? So I think it's really, you know, it's business dependent. You've got to look at what procedures are you targeting, who else is doing that, why are you different, what's going to be the optimal point that you're going to bring benefit to patients, and you're not just going to annoy surgeons because it's not actually ready yet. And I think that's going to be different for each market that you look at, depending on what you're doing. You know, if you're doing, let's say you're designing a surgical system that's going to let you do procedures that no one else can do right now. It's not that surgeons can do them, but we could maybe have a slightly better outcomes, or we could do more in one day, or we could look at teleoperation. Let's say we're doing something truly transformational that's just not possible right now. Well, getting that to market as soon as possible and enabling that to start helping people is pretty important. Whereas if you're fighting in an area that's a bit more contested, like maybe like laparoscopic soft tissue, you've got to really think about what bit of transformational innovation is going to set you apart from everyone else. And maybe that takes a bit more time to develop, but there's no point coming to the market with a Me Too, because you're probably not going to be able to compete. And there are a lot of people trying to compete with Intuitive and Da Vinci, and that is a hard space to compete in. You know, they're the market leader. They've just brought an amazing new system to the market. They spend hundreds of millions of dollars on R&D. So you've got to do something really different to compete in that space. There's no point just pushing out a Me Too and hoping you'll get traction.
Yeah, no, I couldn't agree more. So I'm actually going to get my point, and then I'm going to ask Vincent about something that he sent me. So one of my concerns with all of the regulations and the fear mongering around AI is that countries with less regulation, they will remain nameless. I'm I'm concerned that because they have less regulation, they'll actually be able to advance in AI further and potentially even become the world leaders in certain aspects of AI. And one example is facial recognition software, which obviously has a lot of privacy concerns, but it also if we start studying body facial fat composition, there's a lot of information that we can get that can actually help us with nutritional status of our patients, et cetera. So now I will bring in Vincent. And Vincent, you showed me a video today, which I would actually like you to comment on and see how Alex, when he's presented with something like this, kind of how a company like his reacts. So can you fill in Alex in what I'm talking about, Vincent?
Sure. I just want to get the correct name. So Alex, a friend that I'm worked with a long time, a developer. She's rather interesting. There's a company called Bainbridge that's been working on a concept for a head transplant between you saw that.
I've seen it.
Amazing.
Oh, you have?
Amazing animation. And what I as a researcher, as an AI ecosystem developer and surgeon, I'm always very interested in the ability of the machine to learn across the manifold of other machines performing a task. So a surgical robot that's able to ingest radiology data, genomic data, tissue data, pathology data, and have that in its mind as it begins to perform a procedure or autonomously handle tissue. The ability of touching that tissue, manipulating the haptic feedback, all gets ingested into that environment, and it allows it to learn for the next procedure across the robotic mind of these autonomous surgical decks. We humans can't do that. We can't transfer knowledge between each other, right? We don't have longitudinal memory like that either. So the robots are getting better, faster, smarter. They can collaborate differently. There's an advantage to working with them to some degree, and they're going to be very expensive, and only a small segment, I think, of the population. So we were talking about the ethics of this. Who's going to be able to afford these very radical transformational procedures that will come at a very high cost, where ultra wealthy individuals will have access to quantum computing and the kind of technology that is cost prohibitive to the masses? And how does that stuff trickle down? And think about the Herculean R&D that's required to even begin to address those things. I'm sure you see a lot of this stuff by your customers, the fans, the ones that are looking 10 years out, the ones that have to solve things early. And just some feedback from you on I'm glad you saw that video. We were just talking about that this morning.
It's a really great vision that they've got. I think the reality is we're still some way away from that being possible. So I was at the Hamlin Symposium on Surgical Robotics in London last year. The theme for that last year was AI and surgery. It was a great convention. Actually, the next one's coming up end of June, which I'd recommend to any of the listeners, especially if they're academically focused. And I went to one of the seminars which was about trying to automate surgical tasks using AI. And the way people look at this is they look at a whole procedure and then they break it down into what the different tasks are within that procedure. They classify how automatable they could be, and then they sort of pick out a couple of things to try. And the one that people tend to aim for as a really good starting point is, can I get my surgical robot to automatically suture just two pieces of flesh and just suture them together? And it turns out that's really difficult. And there are some things that make it difficult. And the main thing that does that is the trying to model and predict what the tissue is going to do. So surgical simulation or modeling of tissue is really, really hard. Because ideally what we want to be able to do is, one method we could use for teaching a robot to suture is we could do what's called reinforcement learning. So we could create ideally a simulated environment where we've got our simulated two pieces of tissue, we've got our simulated graspers, we've got our suture, we've got our needle, and we incentivize that robotic system. So we don't tell it how to suture, we're going to try and get it to work it out by itself. So we give it positive scores for when it does things we like. For example, when it, let's say it follows a certain trajectory with the needle, we give it a good score. If it misses one half of the suture line, maybe we give it a negative score. And we simulate that hundreds and hundreds and hundreds of thousands of times, and the system retains its memory of each one of those times. So it learns over time how to do that better and better and better and better. And then we can take that simulation and we can run that on a real model and see what happens. And people can't get that to work particularly well right now. Now, we're still at the beginning of that research in terms of, robotics research or surgical research over time, but we're still quite some time before we can automatically do that sort of procedure. In terms of how does the trickle-down economy work, I think there's two ways that we can increase standard of care globally. We can either look at the bottom end and how do we push that up? And that's what a lot of the robotic systems are trying to do these days. They're trying to get a consistent standard of care for people, regardless of where in the world they live. But we can also, if you think of it as a curve, we can move the bottom of the curve up, or we can move the top of the curve up, knowing that it's going to drag everything else with over time. And that's what a lot of military research has done. Lots of things that were invented for the military, which are not affordable or intended for everyday people, then trickle down into everyday life. And I think it's okay for some research to do that. Clearly, the head transplant is not something in my lifetime, certainly, that every person will have access to. And that's
Oh
okay.
my goodness.
That's okay.
Hold on. I have to discuss the elephant in the room. What about how dystopian that is? What about the ethical concerns are insane with that? I mean, I was kind of thinking you guys were gonna be like, oh, this is, what kind of technology is this? But I mean, this is like a perfect example to me of something which I think is insane. I mean, it'll probably occur in the future in some time, but I'm gonna go on, on record as I think that's completely insane on so many levels. But by the same token, all three of us know that there are billionaires who will be throwing money at a project like this. And, if you throw enough money at a problem, we all know, AI and robotics will be able to solve a lot of these problems. But good Lord, is this the world that we even want to live in? I mean, it is the world we live in, and we don't have a choice. But I mean, it's horrifying, to say the least.
It is horrifying, and I don't see myself signing up for a head transplant anytime soon. But I do think it's important that people with money invest in things that are going to impact everyday lives, and sometimes they're going to do that through things that we won't immediately have access to. But if this means that, this particular example means that someone goes and develops better tissue manipulation models, or better, large language models for processing surgical data so they can look at all the contextual information they see at the same time, or faster ways of doing transplants in general, then that's all good for everyone. And, I think that it's for people with a wider healthcare economy reach than me to decide if that's ethical or not. And as an engineer, I solve problems. Now, I personally wouldn't solve this problem. This doesn't do it for me. But if engineers want to solve that problem and regulators decide that's a problem that we should be allowed to solve, then I can see lots of technological benefit for all of us.
Alex, just a quick question on modeling tissue manipulation, et cetera. We know that primate tissue is very similar to ours. I mean, the vascular tree of a primate is relatively similar, right? Obviously. In your experience, are you seeing a lot of this work being done in primates to do the modeling? Because it's very hard to model in humans. You don't have the volume, but in certain places they have animal models that are a lot easier to work with in an ethical manner. And are you familiar with folks doing a lot of this work within the animal models?
So people will test stuff on animal model, but generally for this sort of process, what I would advocate for is in silico, so on the computer for as long as you can, then
Sure.
with some form of synthetic tissue model, then you can probably go look at some form of cadaver, and then you can probably go look at some form of live animal, and then you can probably go look at human. So that's normally the path that we go through, and you guys know that. In terms of what animal models people tend to use, the easiest to use is porcine, so pig. Well, pigs, dogs, and rats tend to be the easiest ones.
Sure.
It depends where in the world you are to what you're allowed to do. Certainly in the UK, I don't believe you can do tests on primates. I'm not an expert in that area, but mostly pigs. There's a lot of pig cadaver and live porcine. You have to pig tissue is pretty similar to human.
Yeah.
You know, this
Interesting.
conversation is giving me an idea for a paper. I almost feel like we have to write a position paper.
Yeah.
Asking for countries to sign up to ban head transplant. I know. I remember they were working on this. I believe there was a researcher who had to go to Malta or something, like he went to Malta to start doing it. And I remember this was maybe over 10 years ago, I hope. And I remember
Italian
just
guy, I think an Italian surgeon.
yeah. I remember just thinking how absolutely, how chilling, how terrifying it was. But I mean, I wonder if we actually need to, as a journal on AI surgery, I almost feel like we at least have a position, because who knows, maybe my editorial board thinks this is a good thing. I mean, I hope not. My goodness, this is more terrifying than I was prepared to. That was quite the video you sent me today, Vincent. What was the website, just so our listeners can go check it out again? Bainbridge, you said?
Yeah, Bainbridge.
And we couldn't figure out, when you look at under contact information or where they're located, I didn't see an address, which was I almost, honestly, when you sent it to me, Vincent, I was like, I wonder if this is a spoof or a joke, just because, there's no address, there's no country that is affiliated. I'm like, I'm wondering where would they even be doing.
I just gave it a Google, and there's MIT Technology Review suggests that it might actually be fake. So I think maybe we should we should go do our research before we cite it. But
but it's, we know the concept exists, so that's
Sure.
like we already know about this Italian doctor who wanted to start doing it, but
let's face it, the anastomosis for the vascular system, the esophagus and the trachea is not going to be insurmountable. It's just it's the nervous attachment, right? So it's going to be overcome.
Yeah, well, yeah. Hopefully I'll be long dead before that's over.
You'll be the chief medical officer.
I will not. No. So guys, I think we're running out of time a little bit. Vincent, how do you want to? I'm going to let you close us out. I'm glad you Googled it and found that it could be a spoof. I really, really hope it is. I really do.
Well, I think we need to have a follow-up with Alex, because we're all working on innovation, and I was intrigued when he spoke about context switching between the business side of healthcare, the technical side, and the clinical side. And you've got to understand all three legs of the stool to go and build products effectively, right? Otherwise, you build a technical thing, it doesn't have the clinical workflow, or the business guys think they know clinical workflows and they don't. So you have to live in that triad, which you and I, Andrew, talk about all the time. We have extra degrees in those things. Alex, we'd love to have another chat with you about some specifics we're working on, and perhaps talk more about working with your company. So we'll circle back around. So I guess in closing, Andrew, this is episode 48, right, for our artificial intelligence journal, our AI Cybersurgery Podcast. And we thank you, Alex Joseph from Cambridge Consulting, to be on board and give us some insights.
You reminded me, Vincent. Alex, I just want to give you a chance to kind of explain, if people were to reach out for you, which type of people should reach out to you, and what would you tell them, just so, and maybe you could even leave them your contact information.
Yeah, absolutely. So anyone who wants to get a surgical device or medical device to market, who is some way into that process. So I'm happy to talk to people starting out on the journey right at the beginning, but most of our clients have got themselves through some seed funding and looking at building their first prototype to prove that their system really works, to figure out their reimbursement route, to figure out the regulatory pathway. And that's where we tend to engage with people when they're one step further than I've got an idea. They've already started developing that idea. In
Nice.
terms of reaching out to me, on my LinkedIn page, which I think my LinkedIn address is, well, if you search Alex Joseph and Cambridge Consultants,
Yeah.
it's going to come up.
You come up right away.
There's a book a meeting button with me. Feel free to throw in a meeting. I'm always happy to have a conversation about people's businesses and people's ideas. And you're also welcome to drop me an email. It's just alex.joseph@cambridgeconsultants.com.
And you have how many employees?
I should cover that. So we have 850 employees, most of which are engineers, scientists, human factors engineers, industrial designers, photonics, quantum, you name it, we've got them. We have 200 labs, over 150 square meters in Cambridge, UK. We do about 500 projects a year, operating since 1960, and we have generated in that time over 5,000 patents for people. So that is on average a patent every 3 working days.
Wow.
But you do the regulatory all over the world or mainly in the UK? How does that work?
We are able to help our clients get their systems submitted for most geographies. Our expertise is US, Europe, and Japan, but really most of the rest of the world is harmonized to one of those 3. Might be some minor changes, but US and Europe are the big 2.
Excellent. Thank you so much.
No problem. Thank you.
Yeah, thanks, Alex. Next time we're in London, we're going to swing by and see you, okay?
Yeah, please do. I'd really like that.
Okay. Thanks a lot. Have a good weekend, guys.
Have a great weekend.
Bye-bye.